Hello, everyone. My name is Corey Jackson, and I'm a senior health equity analyst from Purdue University. I am with the iHope project. It has been a blessing to be in this community for a year and a half now. To have the opportunity to work with so many amazing, great individuals. I first have to highlight Ms. Tracy Lewis for being a stronghold in the community and allowing the doors to be open for me. There's so many people in this room that I've been blessed to work with, and I'm thankful. In this past year now, being in the community and just professionally and personally in this season, I've taken the time to reflect. The saying says, if you don't know your past, history repeats itself. So I just encourage you all to take the opportunity to reflect. And so in this reflection, I'm in this, what I kept hearing is the window of opportunity. I just kept hearing it, window of opportunity, window of opportunity. I'm not sure if you all are grew up. You may be all be able to feel me on this as I say. I grew up in a house where one of the windows just didn't open. In order to keep that window open, you had to put a stick in there. And so when you remove that stick, it always shut. And so I just want to encourage you all to keep that window of opportunity open because it's always easy to have it closed. So I just wanted to share that with you all that in this season, the window of opportunity is now, and we have it. And so I'm excited to be the moderator for this amazing panel. I'm just thankful to be up here with these prestigious leaders in the community. So without further ado, let's get started. Okay. Dr. Adams, considering your role as Executive Director of Health Equity at Purdue University as a former Surgeon General of the U.S., what are some of the health disparities you have seen in communities related to various chronic diseases?
Well, that's a great question to start off with. And I just want to say thank you to all the community members for showing up and for inviting me to be here as part of this conversation. And that's really what all of this is about. It's about building healthier communities, recognizing health disparities, putting us in a position to be able to be our healthiest selves. That's what health equity actually is. And unfortunately, we know that far too many communities and individuals aren't given the opportunity to reach their full potential for an array of reasons. One of those reasons is the lack of diversity in clinical trials. And so in addition to working at Purdue, I am the chairman of the board of the Association of Diversity in Clinical Trials. So we're gonna have a conversation about that later today. But I wanna start off by addressing the question that you asked, and I'll try to be succinct just by naming a few examples and then looping it back to the conversation. I am someone who has grown up with asthma. Like, statistically speaking, 1 in 7 to 1 in 8 of you all out there. And I almost died when I was 8 years old due to an asthma attack. They had to put me in a helicopter and fly me to the local children's hospital because the hospital near me didn't have a pediatric ward, couldn't care for me. Now, what's interesting about that is Black people are 3 times as likely to be hospitalized to die from asthma. And one of the things that I experienced growing up is something that far too many people of color experience every day. You may have heard that the monitors that they use to determine the oxygenation level in your blood, pulse oximeters, were not tested on Black people. And unfortunately, what we've recently found out is that people with darker skin colors test artificially high on those pulse oximeters, which means that if you come in and you were not getting enough oxygen to your blood, you may be misdiagnosed and sent home. And unfortunately, that's happened to far too many folks, and could have happened to me countless times because I've literally been in the hospital dozens, if not hundreds, over 100 times in my life. We also know that the medications used to treat people with asthma work differently in Black people and people of color than in white people, but they weren't included in the trial, so we didn't know that for years. So I was mismanaged for years potentially as a person of color. That's a place where disparities exist because of lack of diversity in trials, but also because of our situations, because of the environment we live in. We know here in this community there are many factories that are causing pollutants to go out into the air, which can precipitate asthma attacks at a higher degree. We know that housing isn't always safe, and that can precipitate asthma attacks. So that's one example of disparities. Another example of disparities is something I put out a call to action on when I was Surgeon General, and that's high blood pressure, hypertension. And so we know that half of adults have high blood pressure or hypertension. Most of them aren't controlled, and that people of color, particularly African Americans and Native Americans, are less likely to be diagnosed, less likely to have their blood pressure controlled. And that leads to kidney disease, to strokes, to heart attacks, to all sorts of negative outcomes. What's interesting is we know that the medications used to treat high blood pressure often work differently in Black people versus people of color. We didn't always know that, again, because of lack of diversity in trials. And many more examples we could highlight. I've been up here quite a bit talking about infant mortality and maternal mortality. We know that Black moms and Black babies are much more likely to die than white moms and white babies. And that shouldn't happen in a country that spends as much money on healthcare as we do. But we need the data to be able to understand where those disparities come from, and we need to make sure we are at the table when we're coming up with treatments, with remedies, when we're building the systems that are designed to address these problems. So again, we could talk about disparities for a long time. I don't want this to be a negative conversation, but it's important to understand that we're never going to overcome these disparities if we don't acknowledge them. And again, that there are an array of avenues we need to go down to address them. And one of those avenues is by increasing diversity in clinical trials. It's not just about a lot of the issues that people rightly bring up. It's about making sure we're represented so that we actually have better treatments and better options for ourselves and our communities.
Thank you, Dr. Adams, for sharing such an intimate story about your life. You are absolutely right. Disparities can have that negative approach to the community, but we have to realize that diversity is important. We say it often, but it is a reality. We have to be diverse in the work that we do, so thank you for sharing. Dr. Seabrook, what community collaborations should happen to transform and find new strategies to close the disparity gaps and reach communities where they are?
I think that it's very important. I think that it's very important that we, I don't know which one is working. Can you hear? I think that it's very important that we look at our school districts, school corporations, governmental entities, as well as our community groups and social advocacy groups, as we're looking at, how do we have those conversations with the general public and bringing that information and education and about how participating in clinical trials can be a benefit to the community, as well as a resource to the community.
Thank you, Dr. Seabrook. Dr. Neville, what new approaches can faith leaders adopt to ensure collaboration with other stakeholders in healthcare to address disparities in health and advocacy in dealing with health equity?
Thank you. Faith leaders can basically approach and draw on the faith of the congregants. Most persons of faith, whatever their religious belief is, believe that God knows more than we know. They can help in ways that we're not. And so when we call upon that, when we call upon that and we draw upon that, We're inviting God to be involved with the parishioners and the parishioners to be involved in the clinical trials. Now, the approach of that can vary. So if you'll allow me just a few minutes to break it down. A part of it can be the faith perspective of the power of prayer and even the design of the research on the early stages. Then we talk about the clinical trials and the persons that are involved in the trials. But we also want that divine intervention and that divine wisdom to help in understanding the results of the trials. And, what are actually the effects and the benefits and what are the learnings that can be gained while the research is being done. The drawback that some faith persons have is that they feel and believe that God is my protector, that God will watch over me. And therefore, for those that are thinking that way, sometimes they'll come to the conclusion that my involvement in the clinical trial may actually skew the results of the trial. Am I being healed? Am I being helped because of my faith belief? Because God is intervening? Or am I being helped based on the medication, or depending on what type of research is being done, the impact, of that? There's some research that's been done that says even if a participant takes a placebo, if they believe and have the faith that they'll get better, often the results will be skewed because they believe that they'll get, even though they, get the placebo, and so you get that element or that component of it. The other group are those that say, I do not want to be involved in clinical trials or in the research because I don't want to trust the researchers or the medical staff. I believe in faith healing, that God will take care of me. And so, there's a lack of participation from that perspective. As a faith leader, when we are open and honest and have those conversations, then we can view it from a perspective of, yes, we want to help ourselves and our family members, but we also want to help everyone. So that the research and the test that's being done, we're not left out, and that we are being considered in the studies and in the trials. And so that even if God is helping me, I still want the researchers, and from a natural viewpoint, they have a baseline or an understanding of how this will affect me. Do we have the data that's available to support that? And that because there is a portion or a percentage of the population that are people of faith, they're going to be receiving those medications or be impacted by the trials and the research that's been done.
Can I add to that super quick? You talked about a critically important issue that we just got to lay out here, and that is trust. And we know that communities of color, for very appropriate reasons, have mistrust. And so health equity is about giving people not the same thing. That's health equality. Health equity is about giving people what they need. And what we have to understand is that some people need more effort on the part of institutions to build that trust, because there is a trust gap throughout the years that's developed because of situations like Tuskegee, because of situations like Henrietta Lacks. And Corey talked about knowing your history. It's great that we're here today because we all need to help people understand that, yes, we acknowledge that history and we've taken steps to address that history. Many people will talk about Tuskegee. They don't realize that Tuskegee wasn't about what they were giving to people. It was about what they were withholding from people. They actually withheld treatment for syphilis from Black men as part of that study. And people are now saying, I'm not going to take that vaccine because of Tuskegee. Well, actually, Tuskegee was that they wouldn't give people the treatment that they needed to save their lives. And now yourself withholding that treatment because of mistrust. But again, part of it's educating the community, but part of it is us being here like we are today and genuinely showing that, hey, we care about the community, we want people involved front end to back end. And diversity in trials is not just about the participants, it's top to bottom. It's about principal investigators, making sure we have the people designing the trials representative of the community, making sure people at the clinical research sites, the person you encounter when you come in the front door speaks your language, looks like you, is from your community. Making sure we're doing things, and I hope you all get a chance to go out and check out that mobile clinic that's out there. Instead of asking you to come to Indianapolis to participate in a trial at Indiana University or some place that's out of your community, bringing the research site into your community. So again, that trust is critically important, and that's where faith leaders can come in, because quite frankly, I'd rather have your pastor, your rabbi, your minister advising you to take your blood pressure medication, to get vaccinated for the flu, or advising you to participate in the research trial than the Surgeon General of the United States, because you're going to be more likely to listen because you have that trust with your faith leader. So that's why I love this panel up here, because we're partnering with an federally qualified health center, with a faith leader, and with the former Surgeon General of the United States and a representative of Purdue University to say, how can we come together and build that trust that is going to be necessary for people to make that decision to participate in a trial, or even to accept a medication that could be helpful to them.
On that note, I think that you also have to look at the community and gather what their needs are, and not what someone is bringing to them and saying that you need to do this or you should participate in this. What does the community actually need? So a needs assessment should be done with the community voice, just as we're doing right here. What are they saying? What is the community saying that they actually need? What medications, what clinical research, what trials would they be interested in if it met the needs of them as an individual and then their community? Mm-hmm.
I got it right now. Thank you both for sharing the importance of trust. I know we keep saying the term clinical trial. Dr. Adams, this question is for you. What is clinical trial research, and how is it important in improving health equity?
So that's a great question. Anytime you have a new surgery, a new medication, a new device, or even a new behavioral health intervention, we need to test that intervention to determine, is it safe and is it effective before we implement it on a much broader scale to the community. So we need to do clinical trials to determine safety and efficacy. You'll hear those words over and over again. And clinical trials have 4 phases typically. Phase 1 is a safety phase. They use a very small number of participants and they give them a small amount of the medication to determine whether or not it is safe. And then once they determine that it's safe, they will go to phase 2 trials, which look at broader safety and efficacy in the community. They'll test different doses of the medication to figure out, okay, which makes the most sense. And then phase 3 are kind of the biggest phase of trials that happen before a medication is authorized or approved. And the COVID trials, for instance, vaccine trials, had over 30,000 participants in phase 3, looking at safety and efficacy. And I want you all to know, those were some of the largest and most diverse trials in history to prove that the COVID vaccines were safe and effective. But a lot of people don't know about phase 4. Phase 4 happens after a drug has been approved, and that can go on for years. And what phase 4 is doing is looking, because even if we do a trial on 30,000 people, we still don't know 100% for sure what's going to happen in 300 million people. And so phase 4 is looking at what happens after the drug has been approved and is being given to people to see if there's any side effects. So an important part of trust is people understanding that if you have a side effect to any medication, you can and should report it And that reporting goes back to the FDA so that they can determine, okay, is this a real side effect, something we need to pay attention to or not? And you hear a lot of debate about, again, the COVID vaccines and heart problems. Again, hundreds of millions of people have received COVID vaccines since they've been authorized, and there is no evidence that the COVID vaccines are going to be more likely to cause you to have a negative outcome than actually getting COVID. As a matter of fact, the clear evidence is that getting COVID is worse for you by far than any signal within the vaccine. And with the hundreds of millions of people receiving the vaccine by now, we would have seen a signal if there were a significant signal. And I use COVID as an example because everyone's talking about it, but there are many other medications out there that people are hesitant to take, but it's important that they understand we go through 4 phases to ensure safety of a vaccine and efficacy of a vaccine. And you all brought up a point that I want to drive home. I want to say it explicitly. People rightly ask, what's in it for me to participate in a trial? Well, studies consistently show that whether you're in the placebo arm, which is the arm when you're testing a drug, you give some people the drug and you put some people in a placebo arm. They don't get the active drug because you want to test and see whether the drug's working or not. Whether you're in the placebo arm or the active arm, studies show that your health improves when you participate in a clinical trial, period. Why is that? Well, we know many people of color don't have access to a health provider, to high quality health care. When you're in a clinical trial, they're checking your blood pressure, checking your heart rate, often doing x-rays on you multiple times over the course of that trial, sometimes weekly. And so I was actually in Atlanta last week talking to a community forum like this, talked to 2 gentlemen who participated in clinical trials. They both told me, my health improved by participating in the trial period. Why? Because I was paying more attention to my blood pressure. It was getting sent into my doctor. This wasn't even a blood pressure trial. But all of a sudden, someone's paying attention to their health very closely. And so I want people to understand one of the reasons there are disparities in the African American and Hispanic and Native American communities is that people aren't participating in trials and they aren't getting access to that higher level of surveillance and of health care that individuals get when they participate in trials. So that is an advantage no matter what the study is, no matter which arm of the drug you're in, your health on average goes up by participating in a clinical trial.
I just want to add, can we also tie this into HIV and how the advances in HIVs have come so far since the early trials of HIV and the medications that were used. And now we're down to 1 pill when they started out with a regimen of sometimes over 13 pills. So clinical trials do work. African Americans should participate, and as Dr. Adams said, people who participate in trials are subject to a lot of tests and things they would not necessarily be able to get or afford because of their participation in clinical trials.
And also, to be able to participate in the trial, there are some persons that would feel that they don't want to either receive or not receive, depending on what part of the trial that they're in, especially if it's a blind trial. That God can move and work in any case. And so there's some persons that say, well, I don't want to get involved because it's going to bother me. If you take the medication and let's say, unfortunately, there's a negative effect. Well, if you have faith and you believe in God, then God should be able to help you through that negative impact of that medication. Believing in God, if the medication is going to help you, that believing in God is not going to give you a negative impact by taking the medication or participating in the trial. So either way, a person of faith should be able to share, to participate, again, to help themselves, to help their family, but also to help the greater community.
One of the things, our oath is first do no harm. And so I also want to say that clinical trials have been stopped when it has been noted that it is causing harm to the people who are on the medications. and those medications have been pulled or either clinical trials have been stopped. There are clinical trials that have been continued. People who were on placebo were given the medication because they've seen the implications of how good the medication is on those first and second phases of clinical trials. So those are also things that occur. If there's a detrimental effect occurring because of that medication or whatever the research is, it's stopped immediately. First, do no harm. And then if there is a great clinical impact and that medication needs to be brought to the market because it is something urgent like COVID and the mRNA vaccine, then those clinical trials are pushed forward and is brought forward to the general market if it's seen it as for the greater good.
Yep. Thank you so much for highlighting that. That's important for people to know because after Tuskegee, after Henrietta Lacks, we now have institutional review boards. We have FDA and CDC panels. We have people who are constantly looking at different aspects of the trial to pick up a signal like that. And if there is any safety issues, they will stop the trial immediately. They will pull the medication. And so trials have never been safer to be a part of. And in large part, that is because of some of the tragedies that have occurred in the past. They've sparked changes in systems and in protocols to make these trials safer. So thank you so much for highlighting that. And that was one of the so I was involved with Operation Warp Speed, and that was one of the challenges we had was the unblinding. We're like, okay, these vaccines work. So is it fair to keep people in the placebo group if we know that there's a vaccine available that they actually can take? And so we said, look, if we find out these vaccines are working, the second we find out they're working, we have to unblind and let people in the placebo group have access. So again, to your point, it can work both ways. It's from a safety perspective, letting you know, hey, we're seeing a signal, we're gonna stop the trial, or hey, this drug is working better than we ever expected. It's important that we let you have access to the active ingredient. One more caveat that's important when you participate in a trial related to health. All trials now, from an ethical perspective, say that we have to at least give you the current standard of care of medication. We can't take away anything from you for you to participate in a trial. And so when I say your health improves, it's not just that you're getting more testing. Let's say this is a trial on asthma, and I have diabetes and I have high blood pressure. I'm not able to afford my diabetes or blood pressure medication. Well, I participated in an Eli Lilly trial. They have to pay for my diabetes medication, my asthma medication, and my asthma medication. They have to make sure I am getting the standard of care, and that's both for ethical reasons, but also because they're not going to be able to tell whether or not their medication is actually having the impact that it's supposed to have on a population if people aren't at otherwise optimal health. So you get access to testing and to treatment that you might not have otherwise had access to for conditions unrelated to the trial, simply by participating in the trial.
I'd like to go back to the IRB, the review board. The review boards normally will also have a community representative, and often faith leaders, pastors participate in that review board. I've done it, and I know other pastors in the community that are involved in those boards. And part of what we're looking at is to make sure that it is fair, that it is ethical. How are we being considered in the research on the trials that are being proposed to go forward? And if there are questions or issues, that review board is able to say, hey, we need to make some changes here, or we need to tweak it, or to say, no, we do not feel that this should be done in our community. Or to say, yes, we do support this and feel that it's ready to go forward.
Thank you. I wish I had my notebook, but I'm up here, it's all right. This question is for each of you. How can communities come together to collaborate to increase strategies towards clinical trials and just health equity in general?
Okay. I think it is, as I stated in my opening statement, it's important to bring school districts, corporations, governmental entities, community-based groups, as well as social and social activism groups and advocacy groups. I think it's important to have all of these groups at the table to have those conversations and discussion. Again, what does your community need? What does your social group need? What does the school district need? So what those needs are very important when we're looking at encouraging families and communities to participate in clinical research.
Working together works when we work it. Each of us have different strengths and weaknesses in that which we can contribute for the good of the whole. And so when each one participates and we're working together collaboratively, then we get the benefit of everyone. We get the strength of everyone. When we're divided, when we're siloed, then persons are left out, then that representative, we're missing the data, and we don't get the best results that we could get. So we do want to work together.
So I would say it starts with understanding the burden that exists in your community. And you all understand it because you see it and live it every day. But I think that has to be supplemented, compounded by understanding the data. So when I was trying to get $13 million from the state legislature to help combat infant mortality, we had to pull the data, and we realized that many of the highest mortality zip codes for infant mortality were right here in this region. And we would go to those regions, and the policymakers from those regions would be completely blindsided by this data. So we have to demand that we're collecting this data broken down by demographics so that we understand where the problem is before we can adequately address the problem. That's step one. Step two, we need to have events like this where we hear from the community. Everyone from Eli Lilly, can you raise your hand? Okay, so there's the Lilly table. We got to mix you all up a little bit. Where's the Purdue folks? All right, so we got some Purdue folks here. Dr. Jerry Browning is here. I don't know if you all know Dr. Browning. Where are you, Dr. Jerry? He left. Dr. Jerry was a health officer for East Chicago back when I was state health commissioner. We need to have our health officials involved so that we can all work together to deal with these difficult issues, and that you all need to help make sure you know who these representatives are and that you're speaking to us. That's why it was important for Lilly and for Purdue to be here to hear from you all. So we don't want to leave today without hearing from you all and getting your perspective. We also have to understand that only about 20% of your health is determined by what happens in a hospital or a clinic. The other 80% happens in your community. It's access to transportation. It's access to a good paying job. It's access to paid time off from work and childcare. It's access to education. And so part of what we're doing today is showing you that mobile clinic, like I said, so that we can bring our resources to your community. We're going to Bailey Middle School later today, helping to educate young people and helping them understand the opportunities through 21st Century Scholars to actually get a degree, become a principal investigator, a physician, a nurse, a pharmacist themselves, and be part of the system. I think if we're going to address health equity and increase diversity in trials, then we need to really get into that 80% outside of the hospital, outside of the clinic, and make sure that we're where the people are, because that's where health actually happens. It doesn't happen in Indiana University Hospital where I work. It doesn't happen in Lafayette and Purdue. It doesn't happen in Eli Lilly headquarters in downtown Indianapolis. It happens in your communities, and that's where we all need to be.
I think that it's important for, like the mobile unit, for students to see people that look like them, that are healthcare professionals and business professionals representing them. And I just want to tell a little brief story. We have a two-chair dental unit, and we took it out to a community event when we first got it last summer. And our dentist is African American, and he came out and he's talking to the students, and you know they're on the unit and they're getting their teeth examined, and he's having conversations with them, and every child that came out afterwards said that they wanted to be a dentist. So it's very important that we see people that look like us, like you said, participating in clinical trials, but then also being the researchers, the scientists, the doctors, the principal investigators that are doing the research. So this visit with the unit, I'm sure, will have an impact on the students of Bailey Middle School. So thank you for that. We certainly appreciate it.
I think it looks like we gotta wrap up, but I wanna finish with a story. So a question I often get asked when I'm at events, speaking events, is, did you ever dream that you would one day be Surgeon General of the United States when you were younger? I get asked that question all the time. I was just the second African-American male to be United States Surgeon General, just the second in history. And there have been more presidents, twice as many presidents as there have been Surgeons General in the last 150 years. And I had straight A's throughout my entire career. I had the aptitude, but I never had the belief that I could be a physician despite being in the hospital over and over and over again. You know why? Because it wasn't until I was in college that I met an African-American physician. The first African-American physician I ever met in my life, had a conversation with, was at an event like this when I was in college, when I got to meet Dr. Ben Carson. And so I'm a big supporter of the idea that you gotta see it to believe you can be it. And we need to continue to help people see, people of color in all of these different positions, but also see the pathway forward for them when they might not otherwise see that pathway. And 21st Century Scholars, again, if you all don't know about it, look it up. We're going to share information later. Unfortunately, people have to sign up for it by the time they're in 8th grade, and so far too many people miss out on that opportunity. But it is a pathway to college, a pathway to affordable education that many people don't know about. And hopefully, if we can get more people in that pipeline, we can get more people as principal investigators and as health professionals, and help us address some of these disparities.
Thank you. We have so much knowledge and wisdom up here, but I know we took the time and please give them a round of applause. Thank you, Dr. Allen, Dr. Seaberg, Dr. Miller. I do want to also please give a round of applause to Ms. Denise Diller. She was also supposed to be a part of this panel. So thank you. Thank you all. So the next portion, thank you. The next portion is the breakout session. And so we will have Ms. Mayada from the Liberty team to address that. Thank you all.